tracking both parents and children really truly inform ways in which we can fine tune treatment for children.
You're listening to Pedia Pain Focus, episode number 39. And today, my guest shares the instrumental role learning health systems or the big data play in the management of children's pain and for improving treatment outcomes for all involved. So stay tuned.
Pedia Pain Focus.
You're listening to Pedia Pain Focus, brought to you by Proactive Pain Solutions. Pedia Pain Focus highlights pediatric pain information and provides tools and resources for all healthcare professionals taking care of children dealing with pain. Here's your host, Dr. Anjana Kundu.
Hi there. I'm your host, Dr. Anjana Kundu here. And thank you so much for being here with me in another episode of Pedia Pain Focus. Now, I trust you all had a nice Thanksgiving holiday. I'm sure it was quite different than all the other years, thanks and no thanks to COVID. But I'm also positive that there's still a lot that we can all be thankful for. For me personally, I'd say I'm grateful to have the health and safety for myself and most of my family and friends. I'm still gainfully employed, and Proactive Pain Solutions is growing really well. It's thriving. And we have been able to show up and nurture our clients even more so this year, despite all the challenges. As a matter of fact, I would say we were actually well set for this. We were ahead of the curve with the use of technology ahead of time. And I must say, I have a wonderful family, loving friends to share this gratitude with. And on top of all that, I have you, all of my listeners, to help encourage me in living a bigger purpose. So thank you. And I also hope you all took the time, or maybe you're still taking the time to count the hidden blessings despite this very, very challenging year in our history. We know there are hidden blessings like this connectivity we have with each other, the connectivity that has seen new dimensions this year, whether it's in the healthcare sector or education, or even our social networks, our social and personal relationships, right? Thank goodness, or maybe thank the innovative human beings for making it possible so that we can all stay in touch with our families, our friends, our neighbors, patients, whether they're near or afar, and that we're able to check in on them and support each other during these challenging times and beyond. Now, talking about the technology making things possible, this is a perfect segue to our today's episode. We've been on this advent of big data and health informatics in the past decade or so, but this last year, or this current year, I should say, especially has brought them to the center stage with real big spotlights, I'd say Klieg lights on them, really. Whether it is telehealth or databases or a health registry, they had been slowly becoming incorporated into our healthcare system. And this has been going on for years. But this year, it has forcibly catapulted the world into leveraging technology in order to conduct major aspects of our lives, right? We've all seen this, and we're all living through the impact of technology. It has also inspired us in healthcare to take a closer look at what we have and how we could advance more effectively and efficiently in this regard, using the technology to our advantage for the better outcomes for our patients and for us as a healthcare system as well. Therefore, I'm taking this opportunity today to examine and highlight some of the great work that my today's guest has done and contributed to in the area of utilizing databases, registries, or as we call it, the big data for improving health outcomes for children's pain. My guest is Dr. Rashmi Bhandari. She's a PhD, a clinical psychologist, and a researcher who's appointed as the clinical associate professor at Stanford University. She's the director of psychology services for the Pediatric Pain Clinic and also the director for Pediatric Pain Psychology Fellowship training there. Now, Dr. Bhandari has researched evidence-based treatments for pediatric chronic pain and has worked on the identification of important patient characteristics that may inform treatment outcomes. And her focus has specifically been on the assessment and development of treatment interventions to improve the lives of youth with chronic pain. Dr. Bhandari believes that decisions about the appropriate treatments, however, are dependent on accurate and useful data. And therefore, she was inspired by the work of her adult pain medicine colleagues to spearhead the creation or adoption of the pediatric-specific version of a health registry for pain management. It was called the Collaborative Health Outcomes Information Registry, or the CHOIR, CHOIR. And the pediatric version then is called the PEDS CHOIR. This is a novel open source outcome dual tracking vehicle for youth with chronic pain and their caregivers. This registry is utilized by both clinicians to offer patient-tailored interventions in real time, meanwhile creating opportunities to study important predictors and consequences of treatment factors, and this is referred to as the learning health system, which is what we're going to explore today. She will also compare and contrast some of the aspects of CHOIR with some of the other databases and registries that are also out there. So without taking too much of time, I'd like you to hear from my esteemed guest herself. So let's bring her on.
Rashmi, welcome to Pedia Pain Focus. I'm so happy to have you.
Thank you so much, Anjana. It's my absolute pleasure to spend this time with you.
Oh, the pleasure is all mine, and I can't wait to dive into our conversation and share your expertise, which are abundant. But for today, I would love for one of your major works, which is sort of the patient outcomes-based database and data registries, that I would love to explore today. But before we go there, before we dive into the nitty-gritty of our conversation today, I would love for you to share a little bit about yourself with the audience. Tell them a little bit about Dr. Rashmi Bhandari and how you landed in pediatric pain medicine and how we were lucky to have you as such an amazing psychologist.
Well, thank you. Thank you again for having me. You may know this about me already, Anjana, but I was born and raised in Tanzania, which is a country in East Africa. I became a kindergarten teacher, always loved kids, always loved working with children, and wanted to pursue psychology. And in East Africa, we don't teach psychology in college, which involved that I would travel to the US. And that's why I came to this country, studied psychology, became a clinical psychologist. And my focus was never pain medicine. It was depression and OCD. And then while I was doing my postdoctoral fellowship, I was called on a very interesting case that sparked my interest. I was consulted on a case of a beautiful 3-year-old who had extensive burns on her back as she had walked back into a boiling pot of water her mother was using to warm their apartment. And so she had sustained extensive burns, and I was consulted because she was unconsolable. And I had to be a part of her daily Band-Aid changes. And that just sort of inspired me in the work that we can do to bring comfort to the lives of children. And then, as fate would have it, Stanford Children's had a position, and I met the inspirational Dr. Elliot Crane, who further convinced me the importance of this work. And I had to work with him. And that's why I landed in the world of pain medicine. I was trained in the practitioner scientist model at Wayne State University. And so it was very important to me that the work we do is informed by science and it's evidence-based, which sort of triggered my interest in registries.
That's amazing. What an incredible story. And I did not know that you were a teacher. Wow, that's awesome. So shall we dive a little bit into, like, before we actually talk about your specific database, data registry, why are health registries or databases so important for pediatric pain management?
Sure. Chronic pain etiology is often unknown, right? It's a hidden disease. It's without observable disease markers, which really renders a very heavy reliance on self-reported symptoms. And also, we know that pain is understood and treated using this sort of biopsychosocial model, right? Registries, they are able to use reliable and valid pediatric measures of physical, psychological, and social domains that are relevant to chronic pain. And they are able to sort of measure and predict and allow us to understand the variables for adaptive and maladaptive pain coping. The beauty of the learning health systems is it uses the technology to partner with patients and clinicians to continuously, right, on the back end, improve the accuracy of assessments and offer support to those of us that are clinicians, right, in our daily clinical decision-making practice. That's the value of the learning health system, particularly for chronic pain.
So basically, not only allows us to be able to identify some patterns and stuff, but also evaluate what we're doing and course correct if we need to, is what my simplistic way of going with it.
Absolutely. Spot on.
Great. So Rashmi, tell us about the learning health systems that you have been involved with.
So this started about 2014 for us, but prior to that, the Stanford University Division of Pain Medicine, in collaboration with clinical informatics, developed this system called CHOIR, which stands for the Collaborative Health Outcomes Information Registry. Its founder, Sean Mackey. And CHOIR is basically a free, open source, open standard, flexible system that runs on sort of the secure Oracle database that's HIPAA compliant. And it uses that web-based interface to capture data at each clinic visit. And the beauty of the registry is that it is instantly available. The patient presses submit and the clinician sees an instant graphical real-time results that can inform your point of care decisions and track at the back end your patient's treatment response longitudinally. In aggregate, this is what big data does, right? It can be used to phenotype patients and characterize their response to interventions. And so PEDS-CHOIR, which is sort of what we have done at the Pediatric Pain Clinic with just incredible other support systems and faculty, is an adaptation of CHOIR. It is an adaptation for the pediatric setting. What we did is we added another track, a dual tracking capacity, which would track not only the patient's response to treatment, but also, as you know, the important response of the caregiver. We added a dual system where you can track both the patient and the caregivers, and it includes both the classical testing theory-based measures like the pain catastrophizing scale and fear of pain, all of these very valid gold standards in our field, as well as the National Institute of Health's PROMIS measures. You've heard of those, and they're very popular and they're incredible. And what PROMIS is, they're item response theory measures, and they're administered in the CHOIR system via computer adaptive testing technology. And that what it does is it helps decrease the responder burden because they're getting the exact number of items that it takes for the system to capture that domain for that patient at that time. So instead of filling out a short survey that might be 8-12 items, you are perhaps getting a 4 or 5 item survey to capture your domain where you are at that time. And so it allows us to really capture the patient and the caregiver data in real time. And PEDS-CHOIR is kind of a combination of both the classical testing data as well as the IRT measures.
So Rashmi, we know that any pediatric healthcare professionals We shout from the rooftops. We make sure that everybody knows that kids are not small adults. As a matter of fact, one of our recent episodes was totally dedicated to that. We talk about how needs of children are unique, how children are unique in how they process information, how they respond, what applies to them, right? What implications anything has with them. When you were changing the adult choir to adapt to the needs of children, what were some of the components that you specifically looked at and made sure that they were more specific in capturing the uniqueness and unique aspects of pediatric pain?
Yeah, that's a great question. Obviously the developmental stages of children, right? You want items to be readable and understood by the child. So we have two versions, one for kids that are younger, and the measures kind of grow with the child because they're made for that child for that age. It's reliable and valid. The languaging, how we express, we ask questions have to be developmentally attuned to the child's level. The reading level has to be respectful of the child's learning differences. And the biggest difference is capturing the caregiver data. We work in the pediatric setting, understand the value of a caregiver contribution. That was the biggest difference, is that you're using children's valid measures that are specific to kids, known to be great indicators for outcomes and predictors, as well as capturing the parent data.
And maybe I'm putting the cart before the horse here, but what did you find was different between the parent or caregiver data versus the children's data?
This is perhaps something that has been captured by multiple other studies, but across the board, we find parents to be just so much more worried, right? Across the board, pain reports are higher by caregivers. Pain catastrophizing tends to be higher as reported by caregivers. Level of anxiety, level of depression reported via proxy report tends to be higher in parents. And we actually have a paper that describes that parent-child discrepancy in reporting. Yeah. And I think clinically that becomes very relevant when you are working with a parent. Parents across the room from you, something that happened a while ago. Now we haven't seen parents in a long time in person.
Right.
You display this graphical data and you show them that, hey, listen, this is sort of what you're thinking is going on. Your kid can't move. Your kid is feeling this much fatigue. Your kid has that much pain. And this is where your child is. How does this make sense to you? What do you think about it? And often what I find is parents have this like, wow, really? My kid's feeling much better. And there is this huge, relief, and you can see their shoulders kind of come down and you can see the smile emerge on their face. And they realize that maybe it isn't as bad as they thought. And on the other hand, sometimes kids are underreporters or maybe don't even recognize the level of discomfort they might be in or the sadness they may experience or the worries that they may have. And parents become a wonderful proxy for those types of queries that can be informed. So tracking both parents and children really truly inform ways in which we can fine-tune treatment for children in the clinic.
Right. A couple of things that I'm hearing you say, Dr. Bhandari, is one, that it is a real-time data of not just we're just capturing data and then you go back and look at it at some other point. With some of the big data, information does operate that way, like you input the data and then you go back and analyze. So what I'm hearing is that it's almost a real time. You got the data, but you have the output right away. And it is a visual representation of what is going on the trend of their child's pain or of their own pain in cases of children. It is a real-time feedback. And when we look at something visual, it has a huge impact, obviously, as you were just explaining. What a great tool in that. The other thing that I am hearing you say, and I think this is a great tool that reconciles sometimes the discrepancies or the perceptive differences that we may have in, whether it's the child versus the parent or child versus the healthcare professional or the parent versus the healthcare professional. It's actually a great source to compile that information in a very meaningful way so that there's a great way to move forward together.
Yeah, you bring up a very, very important point that I think I have valued the most out of these learning health systems is this ability to engage, right, Anjana, and collaboratively work on valued goals, right? Often physicians and clinicians, we come to the appointment with our own sort of goal, right? Here's what we want to do. Here's how we want to help. And what the kid and what the family and what the caregiver really is experiencing often can get, it's hard to focus on that. And what choir does, it sort of brings it out really front and center. And you are able to have a collaborative kind of communication with the child and the caregiver around what's bothering them most. Because we don't have time to evaluate all of these different biopsychosocial variables that we understand to be really important at every visit. But when you have this sort of pictorial version of what is going on, it's often valuable for both the clinician and the patient. And in fact, to give you an example, as someone who works with children, you know how hard it is for kids to be invested or bought into the things that we understand to be really important, such as sleep, right? We know how incredibly important sleep is. And I've had so many of these aha moments where a kid might look at a graph and think to themselves, like, okay, Dr. Bhandari, when I was sleeping well, my pain was doing well, it was trending all the way down together. And suddenly my sleep is over here. And I understand why maybe I hurt more. Looking at the pictorial version of what they themselves have inputted right before your session, it really puts things together for them in their brain and then brings them to that table for a joint collaborative approach to treatment. And
more engaged person.
More engaged, more bought in, more you kind of understand. I've had kids who come in and they've worked with me maybe for 6 months and they'll look and they'll say, wow, during the summer, things look really good on this graph. As soon as September came, I kind of fell off the cliff. And I might say, well, what do you think about that? And, and then they may get to that point, like that, school's really stressful and perhaps that. And so we can drill down. Stress needs to be better managed and stress contributes to pain, but there's nothing more valuable than seeing that graphically displayed in front of you and for you to make those connections by yourself.
Right. Yeah. And so the whole adage, picture is worth 1,000 words, right?
Absolutely.
It's right in display. Yeah. That's amazing.
Kids are very concrete in the way that they can grasp information. And this is a very concrete way and a very therapeutic way of working with kids.
Were there any surprising elements, good or bad, that you found when you engaged in this work?
The benefits just have been astonishing. Nothing that I had ever anticipated, but have been just the ones that we have discussed, Anjana. The idea that you can take a look at something that pops up on your computer and know, oh, I need to really talk to someone's physical therapist because mobility scores are tanking, right? Or I need to really get on the phone with my medical kind of colleague to figure out what's going on. This pain is just not getting better, despite the fact that anxiety and depression are improving, right? This idea that we can bring in the valuable collaborators in a multi-disciplinary clinic because of something that you are just looking at and tracking is just so valuable as a clinician who works with kids. And even just this triaging, right? Triaging of a lot of times I have colleagues that will come up to me and say, they were doing really well. And I didn't know they needed you. I didn't know they needed a psychologist. But I looked at their choirs and their anxiety and depression scores were really scary. So I thought I'd pick up the phone and get one of you guys on board. This idea that you can reach out to collaborators and triage accordingly is really a big cost-saving contributor to the child, the patient, the system. and an efficient way of treating pain. And what I have noticed is that during the social distancing and telemedicine phase of doing treatment is that we aren't necessarily capturing and tracking our patients as well as we would like to in the face-to-face setting. Front desk staff isn't doing all of the various indicators or asking the various questions. Having this sort of pictorial version of what's going on, it really helps save my time, where I don't have to ask questions about sleep all the time. I don't have to ask questions about how they're doing with stress all of the time. It's just right there for me. It really helps me kind of deep dive into the more important things versus the time kind of in the things that are already captured for me. And so it's been a time saver. It's been a great way to engage. And patients are feeling like they are being tracked. They're being followed. Someone cares for them.
Right.
When we say something, I looked at your choir and I noticed that over the last few months, things have been just consistently getting better and better. Like, what are you doing? How are you doing that? And that just has this sort of smile emerges and like, yeah, I've actually been putting my phone away at night. And so this sort of like ability to truly say, I've been watching you, I've been looking over your shoulder and I care about you. And our satisfaction.
I'm with you on this journey, whether you see me or not. We're together. Yeah.
We are together. And, our satisfaction rates have continued to be very good despite having this sort of inability to see the patient in person. And I think choir has played a role in that.
Beautiful. That's great. You mentioned about cost efficiency, and absolutely makes sense. It's time efficient for sure. But cost efficiency, so talking about that, what are the costs that we're looking at implementing such a learning health system, or specifically Peds Choir?
It is a costly system. And we were lucky that we were in a university setting where it was developed. We already had the infrastructure in place and we adapted and we were able to continue utilizing the framework. For another institution to adopt choir, they would have to have the IT system, that sort of infrastructure where you'd be able to house choir and you'd be able to collect the data and save the data because it takes a lot of sort of memory to store. Our startup costs were $50,000 to $75,000. And the beauty of choir is that whatever has been implemented can be inherited for free, right? You can choose as your institution decides which measures to kind of add or delete. But what has already been, all the infrastructure, all the resources that have been put in, you get to have without additional resources on your end. But the upkeep can be expensive. For us, it's running anywhere close to about $5,000 a year. Really, it's an ideal system for an academic institution. Wouldn't be something I'd recommend for someone who has a small practice. Those practices, you may want to adapt things like REDCap, like Promise, be able to utilize those systems, which are readily and freely available.
Right. Great. Do you have a sense of comparison of what you gain or lose with choir versus the REDCap or Promise or any other learning health system or databases?
Personally, never utilized Promise in the REDCap version. I think that I love is the fact that I can combine some of the classical theory measures with some of the IRT measures like Promise. I particularly like the idea of the patient sort of submitting their data and as a clinician just instantly getting it. This idea that, people are not just doing their measures and then down the line you're reviewing what they did, but that their data benefits them. And I know that in the REDCap version, you can do that. You can put things together and it will spit out a sort of immediate result, but it's not graphically kind of tracked, which again, I really love the whole graphical piece of this industry where you can track and see. And I'm sure that there's a way to do that, but I'm not as familiar with the REDCap version of Promise measures. I feel like there is pros and cons to both systems. And I think the ideal way to choose something would be which setting you are in. What are your resources and what is your need? Since we've been tracking kids with choir, we've seen over 1,500 kids whose data now is within choir. Those are quite a few kids that we've seen over the course of the last few years. Those are not the numbers you're working with, then perhaps a smaller data infrastructure could be more relevant for you. We were grateful to have Choir developed at Stanford, more easily, readily adapted, and Sean Mackey, who were very incredibly generous with the process and truly held our hand every step of the way. I believe that it was one of those things that sort of landed in our laps, and we were just lucky for that. I am familiar with EPOC, which is a Australian-based registry called the Electronic Persistent Pain Outcomes Collaboration. And that's another sort of big data registry that is taking traction. And then Boston Children's has another registry called WeCo. There they are tracking clinics with like rheumatology, the orthopedic clinic, and all of the different places in which chronic pain is prevalent, to see how having these different diseases kind of come together for people who have chronic pain. This is the beauty of these registries, right? I mean, I think that as a clinician, to be able to have access to data and be able to ask important questions and be able to track and get those answers. Over the last 5 years, we've been able to publish, with over 10 papers just from Choir data. And these are coming out of people who are primarily clinicians like myself. It's just a dream come true when a clinician might think, I'm really feeling this is happening, and this is what the research is saying. Like, what is our data showing? The good news using data in this kind of real clinical way is that it's who we are actually seeing, right? So when you look at some of these randomized controlled trials, Anjana, they kind of have an exclusionary criteria for a lot of our patients. Suicidality, high, very severe levels of psychopathology, people with learning differences. I mean, they're excluding so many of these patients that we see. They are our bread and butter. We see them every day. But a clinical registry like Choir does, it's very inclusive, and it really allows you to take a look at some of the big data, the phenotype of what we're looking at in the day-to-day of what we do.
Excellent. Rashmi, you just said that it's best or ideal. Peds Choir is ideal, or Choir is ideal for an academic institution, perhaps partly because of the cost involved. There was an institution that was interested in jumping on board and just like, we love this tool, this database, this learning health system, and we would love to have access to it or implement this at our institution. How would somebody go about ensuring, or is this exclusive to Stanford?
No, not at all. We have several institutions that are under the process of incorporating Choir into their infrastructure. Some of the questions to ask yourself first and foremost is, do you have IT support? Would you have the ability to store this data? Would you have staff that can truly hold your hand? Because it's a collaborative process. Choir is usually sent to the caregiver's email through like a secure HIPAA compliant server. And then it's talking to your electronic health record to say, oh, here's your appointment. So 7 days prior, you get sent to Choir. Some of that, so think about some of those infrastructure things as you are contemplating adopting Choir. The actual steps are fairly simple in the sense that you can either contact me and I can put you in touch with the relevant people. To initiate the adoption, you would basically contact Sean Mackey and his group. It's smackey@pain.stanford.edu. There is a licensing agreement that his team would send you, and you would look that over. Then they would sort of talk to each other, ensure that you have the necessary kind of IT support system. And it's easy as that. There is no cost involved in actually, getting Choir, but there's cost to keeping Choir. And depending on, what you want to add, measures that you may want to add, and so on and so forth. I think that is the whole premise of a learning health. It's a common language, right? More institutions that are utilizing it, the more data that can be combined. Thankfully, your data is your data, and you can choose to do whatever you do with it. It doesn't belong to Stanford or anyone. There is an opportunity then, because you're all talking the same language, is to sort of aggregate data across institutions and do some real phenotype analysis of the kinds of patients we see and what works for them.
Right. And it'd be interesting to see if there are any regional variations or anything of that sort if you are obviously using this as a collaborative measure. As we all know, as pediatric healthcare professionals, whether you're doing especially pain, that the population is so small. So there's a power in doing this together.
That's right. And, interestingly, in California, 30% of our patients are Hispanic. So we have this incredible opportunity to take a look at how best to serve that group. We're developing Choir or REDCap and utilizing the Spanish versions and trying to truly figure out a way to do that and for that population. So like you said, regional differences and cultural differences and
ethnic and racial differences that can also be tracked. Yes. And especially when we talk about diversity and incongruous sort of healthcare practices, these measures would be great in looking at those disparities.
Exactly. Disparities are very important. None of that work exists right now. And so that is very important work that we need to focus on. And
excellent.
That this registry would allow us to do that.
It seems like it would. It's great. But I'm going to go back just one step and have you clarify something for me. I know you said there's no cost for acquiring Choir, which means, does that mean that Stanford isn't charging any licensing fees per se?
No.
So no licensing fees. But then earlier in our conversation, you'd mentioned that to set up we may be looking at a figure of about up to 50,000 or close to that. Is that still what the approximate cost is to set up Choir at an institution?
You're asking a really fantastic question. So there's two collaborators, Children's Wisconsin and University of Michigan, who have recently incorporated Pete's Choir into their system. And this would be a great question to ask them to see what their startup cost was. I mentioned that figure, which was our startup cost, which was large, mostly because none of these measures existed. We were creating a pediatric version for the first time, right?
Correct.
When you are inheriting the system, all of that is inherent in that system. And the cost would be different, but it's a really, really good question, and I will get back to you the answer.
I'm sure, given what an incredible tool this is, I'm sure there will be people that be interested in knowing and wanting to evaluate their options, how easy or difficult it might be for them to adapt this.
I was just saying, I think it's every clinician's dream, right? To step back and to ask oneself, what is it, who is it that we're seeing, and what is it that they primarily come with? Because we day to day get really absorbed in our patients and doing our best for them. To step back and to get this data and to know, 30% of your patients are boys and 30% or male and the rest are female, and to know that 30% present with musculoskeletal pain, or to get that kind of phenotypical data of the people that we're seeing, and then to be able to see baseline to 3 months that, in fact, their pain does go down, and in fact, their mobility improves, and in fact, that their depression and anxiety are getting better. I think that is such a satisfying experience for clinicians.
Right. And so meaningful for all involved, right? Meaningful for the healthcare professionals, of course, the patients and families, and healthcare systems per se, right? So you're using your resources and your time way more cost efficiently in a much more engaged way, as you said. And clearly seems like for better outcomes too. So it's a win-win situation as far as I can see.
A win-win, for sure.
Good. Anything else that you want to add to this, Dr. Bhandari?
This is a challenging time, right, for all of us, Anjana, and all of us, especially for our patients who have chronic discomfort. And I think that we're all doing our absolute best. And my message would be to be kind and compassionate to yourselves as you work every day. And I just wanted to say thank you to all of you who are listening, who do this important work every day to mitigate the challenges of kids and their families who have chronic pain. A great deal of gratitude.
how can people contact you?
You can email me. It's rbhandar@stanford.edu, and happy to chat. Well, I'm available to anyone who might be interested to chat more about this. Have a lot of papers that people can read about what choir is and what choir can do. I think that whether it is a small few kind of combined measures or a larger infrastructure like choir, it's critical that for those of us that work with kids to be informed by data in the work that we do every day.
And if you are up for it, I would love to be able to include those papers for reference for people in the show notes. So if you want, we can include all of that in there as well.
The title and the abstract, would that be
perfect? Well, Dr. Bhandari, thank you so much for taking the time. This is amazing. And even though I'd been at the presentation at SBPM several years ago and I'd heard your fantastic talk, I just thought, of course, it would have evolved since then, as well as the fact that there were so many great things that I had totally missed that time. It's so good to hear the information as well as the evolution again. So I'm so grateful for you taking the time, sharing your expertise, sharing this amazing tool with our audience. And I just can't wait for this to be published and more people to hear about this.
I'm excited you invited me, Anjana. Please stay well. Please stay safe. And I hope we get to see each other soon.
Yes, that would be lovely. I can't wait for that time when we can see.
Thank you so
much. All right, thank you so much.
There you have it, folks. How wonderful was that? As Dr. Bhandari mentioned, there are several of these data registries and learning health systems. You may explore others, but if you're interested in exploring Peds Choir, make sure you get in touch with her. You know that it's free and it can help you give real-time information for yourself and for your patients. And what more can one want when you can take a look at the exact picture of what's going in your child, in your patients and in your child's, and or in cases of patients in their own lives, and be able to make adjustments as we go along. How much more effective can anything be? So make sure that you are able to look into this. And as Dr. Bhandari said, there is power in numbers. The more people that follow these registries are participating in this big data, the more numbers we have to look at and a better assessment it is of our interventions and the effectiveness of whatever we are doing to help our patients and families. It lets us examine it on a bigger stage and gives us even a comparison of regional differences or any other factors that may be playing a role into it. I would just say, jump on this ship, make sure that you are able to empower yourself and your patients to the best possible outcomes. Now, as always, I encourage you to subscribe if you haven't already to our podcast. Make sure that you continue to learn about all the new episodes that we are bringing and sometimes the bonus episodes as well. As you know, we have been doing these weekly at this point. So I am busy preparing even more engaging and wonderful episodes that are in the lineup for December. So I look forward to talking to you in a week. Until then, stay safe, be proactive. Bye now. Pedia Pain Focus is a presentation of Proactive Pain Solutions, a company committed to transforming pediatric pain care through improved access, quality, and expertise. There is a large gap in children's pain management. Did you know 1 in 3 school-age children are suffering from chronic pain? That's 19 million children in the U.S. alone. Meanwhile, there are only a handful of programs that provide pediatric pain medicine training. This leaves children's pain in the care of hands of untrained healthcare professionals and results in frustration for both the groups, patients and their healthcare professionals. Data clearly shows that untreated or poorly treated children's pain leads to much higher incidence of chronic pain into adulthood and mental health diagnosis and a huge societal burden. Proactive Pain Solutions Academy is the answer to this major problem. It fills this large gap through our comprehensive, evidence-based virtual training, which is bolstered by live Q&A sessions, personalized mentorship, and leadership training development. Now, our enrollment only opens for a limited time and only for a limited number of spots. So join our early bird waitlist today and be the first one to know as soon as our doors open. You don't want to miss out on this opportunity to have the expertise at your fingertips, the expertise that will help you improve your patient outcomes and satisfaction as you watch your own confidence and professional satisfaction soar. So join us today.